Our next session is devoted to the Lifetime Achievement Awards, but I'm going to preface it with two awards that we'd like to give to Mario Gaudino and to Gianluca Torregrossa. These are not Lifetime Achievement Awards. These are an expression of gratitude from the International Coronary Congress for the extraordinarily hard work that they have done as program chairman. Mario for 3 years and recently to this year, Gianluca Torregrossa, who really carried a tremendous burden this year and did a fantastic job putting together this program. None of the great lectures and the academic excellence that we've enjoyed over these past 4 years would be possible without these two gentlemen, and as we have a token of our gratitude.
Out of surprise. Thank you. Thank you. Thank you. Very much.
Super.
Thank you.
Do you want to go first?
So first of all, I must say that being the program chair is probably an Italian affair, right? We went from Gianluca from me to Gianluca, so there must be something in Italian's blood that makes us a good program chair. But as every year, the ICC award some of us who have really provided an important contribution to the field. Over the course of the year, the giants of coronary surgery, and not only coronary surgery, because we had also interventional cardiologists in our list of awardee, have been given this recognition. And it's really surgery, it's something that is developed by each generation. Each generation goes a step forward, but some of us are more important in making those steps. And those are the kind of people that we recognize. And it's really special for me to award the ICC Lifetime Achievement Award to Gianni Angelini. And by the way, to the tech people, that's the wrong presentation. That's Gianni. Yes, that's Gianni. It's really special for me for two reasons. First of all, because Gianni is a role model. Gianni is a legend, I think, for every coronary surgeon, for every cardiac surgeon, but even more so for Italian cardiac surgeon. He really represents everything you want to be. And on a personal level, this feels very special because even though I've never worked surgically with Gianni, I think of Gianni as one of my mentors. I did reach out to Gianni in several situations in my life when I needed senior advice, and Gianni was always there. And he's a man of few words. He doesn't sugarcoat things. He will tell you things how they exactly are, even when you don't want to hear them, but that's exactly what you need from a mentor. So thank you, Gianni, for always being there. Now, I had to write something to summarize what Gianni has done. And I will, for sure, not make justice to everything that he has done. But among the few things, Gianni is Emeritus British Heart Foundation Professor of Cardiac Surgery and Emeritus NIHR Senior Investigator and Fellow of the Academy of Medical Science. In 1996, he established the Bristol Heart Institute and have been the director of the institute since there. The institute is an international center of excellence comprising more than 300 scientists and has raised funds for over 90 million of British pounds since its inception. Gianni has led multiple clinical trials in the coronary ward and in other fields. I was joking with Gianni yesterday by saying that most of what you see in our program, minimally invasive coronary artery bypass surgery, off pump, hybrid, a focus on reduction of blood transfusion. Those are topics that Gianni was exploring 20 years ago. So either he was really at the forefront or we are slow as a community. But the reality is that he wrote seminal paper on essentially all the key aspects of coronary surgery. Gianni also has spent considerable time and effort in humanitarian mission. In 1993, he founded the first cardiovascular unit in the English-speaking Caribbean and was responsible for organizing the unit and training the personnel. Now, the unit is independently managed by local physicians and performs approximately 450 cases per year. He did similar work when he was asked to restructure the cardiac surgery server at the Chinese University of Prince of Wales Hospital in Hong Kong. Gianni in 1996 established the first cardiac surgery database in the UK that became essentially the blueprint for what is now the UK National Cardiac Surgery Database. He, during his dual position as BHA Professor of Cardiac Surgery in Bristol and at Imperial College, he turned around the clinical service and facilitated the interaction between clinician and scientists. And this is really Gianni's view. So I have only one other slide. I think I have. I don't, yes. And this is really one of the great lessons I learned from Gianni. And I've heard Gianni saying this multiple times. At that time, I was telling him, look, I really want to be a surgeon scientist. I want to do surgery, but I also want to do research, in my case, clinical research. And he asked me, but are you really sure you want that? And I said, yeah, sure. Why not? I think this is the best thing in the world. He said, well, you need to be careful what you want to do because it's not really easy. And it is sometimes really hard to be what you want to be. And then he gave me this analogy. He said, the surgeon scientist is a guy standing in the middle of the bridge, as in this slide. And this bridge connects two very different lands, the land of research and the land of clinical surgery. And people who live in the two different lands look at the guy standing in the middle of the bridge, and they don't really understand him. The surgeon, the clinical surgeon, look at the guy and like, well, he spends so much time doing his research, he cannot be a really good surgeon. And people who do research look at the guy standing in the middle of the bridge and say, well, he spent so much time taking care of the research of the patient that his research cannot be as good as ours. So you really need to be fully committed and strong, Mario, to be what you want to be. Well, I did persist, and I'm happy I did. But most importantly, I'm very grateful for not only for what you have done for me, Gianni, for everything you have done for the field. So congratulations for this award. It's fully deserved.
Too nice.
I think you have a presentation, right?
Yes, we have. Oh, I see. The prize first and then the presentation. Thank you very much.
Yeah, okay.
Oh, we lost the photographer.
There we have a photographer. Super.
Thank you. Thank you. Can I have the slides, please? Thank you, Mario, for the very kind word, perhaps not entirely deserved. And thank you for inviting me to the society. Somebody said, I'm still practicing, by the way, but somebody one day told me that The only time people say nice things about you is when you retire and when you die. But I know that Mario is really genuine in his feeling. As you heard, I'm another Italian. And in fact, I was born in Siena, which is a small medieval town in the middle of Tuscany. And it's famous because twice a year there is a crazy horse race around the main square. So most people who are from Tuscany, they say, well, this guy must be one of my ancestors. And indeed, he contributes significantly to the anatomy of the heart. And if you want to see those things, actually, they are not very far from here. They are in Windsor, property of King Charles. But if you make a request, they will allow you to see it. Of course, Leonardo was interested in all sorts of things. The only things he didn't have was an engine, actually, which took another 400 or 500 years. But let me tell you very briefly about me. As a young boy, my dream was to be a pilot flying aeroplane and possibly sitting on the cockpit of Concorde. And that's why I went to medical engineering. I had no intention whatsoever to be a doctor. However, throughout that time, I had a little problem with my left eye, just a small grain of steel, which needed to be removed. The eye was subsequently patched just for safekeeping for a few days. Then I realized I can't see anything from the right eyes. To cut a long story short, I'm amblyopic, which is a congenital abnormality, and more or less I got one eye, which doesn't go very well with surgery. And usually, obviously, I don't divulge this information to my patient, at least not until after. So my future as an airline pilot was over even before it started. Now, again, in my country, we say to be an engineer, you have to be really clever. To be a doctor, well, not that much. And of course, if we look at coronary surgery, this is really nothing else but straightforward plumbing. So I went to my university in Siena, which was founded in 1240, one of the oldest universities in the world. And here, this is the hospital where I trained, which is now a museum. Now, the inside of the hospital is all painted with beautiful painting. And in fact, the one at the top, actually, is the post-operative ward. So as a medical student, our main occupation, once the patient was waking up, was to tell the patient that they were still in the land of the living. They had not gone to heaven. And as a matter of fact, even the good Catholic, they were actually quite relieved because there was plenty of time to go to heaven and live it as long as possible. So after this, I became a doctor. I came to the United Kingdom in 1979, and with the exception of some time in Holland, this was all my training. And as I said before, coronary surgery is nothing but straightforward plumbing. However, one of the interesting things for the one of you particularly who are much younger than me is to look at what happened over a period of 20 or 30 years. When I was first introduced to heart surgery, the mortality in the United Kingdom for straightforward coronary surgery was more than 25%, 1 in 4 people who died. Early 2000, the mortality had come down to 2%. Nowadays, probably is in the order of 1%. It must be one of the most safe operations ever performed in the world. And this gentleman here on the right, called Sir Ranulph Fiennes, regarded by the Guinness Book of Records as one of the most famous explorer, he actually crossed Antarctica on foot unsupported, had a cardiac arrest when boarding a plane in Bristol. I did his operation, which was not a big deal. But believe it or not, 6 weeks after his surgery, he ran 7 marathons in 7 days in 7 different continents, complement of British Airways. So we're obviously doing an operation which works, although I'm not expecting all our patients to achieve that level of recovery. Of course, we are here because of lots of people who have made this possible. I'm not discussing or I'm not suggesting who did the first coronary operation, because probably you got your own ideas and you know more than I do. But certainly we wouldn't be here if it wasn't because of the development of the heart-lung machine. some of these people actually, believe it or not, are not terribly old. I knew them and I met it in person. And here at the bottom is a group from the Hammersmith Hospital. The one with glasses is Hugh Bento. I'm sure you know who Hugh Bento was. And of course, again, none of this would have been possible if there wasn't the development, accidentally apparently, in 1958 of coronary angiograms. So these people have contributed, there is no question. Lots of other people in my book have had a profound influence. And one of the most important things probably which allowed us to do what we do nowadays is the development of cardioplegic solution. They were different people developing this in the USA, but in this country, David Hurst, who was a scientist, a PhD, together with a surgeon called Mark Brembridge, developed what is nowadays still used as a St. Thomas cardioplegia. And this changed everything. I remember as a young trainee doing, not myself, but looking at the surgeon doing the operation with intermittent cross-calcium fibrillation, which was a complete nightmare. And if you had to do an aortic valve replacement, you had to cannulate and continuously perfuse the coronary ostium. Of course, the cannula kept coming out and spraying blood all over the operating theaters. The other important development from Dr. Green was the introduction, or I should say, the intuition of using the left internal mammary. I have known him personally, and in fact, I've done some work with him in the past. And interesting, in 1966, this guy was actually anastomosing left internal mammary into the LAD of dogs when nobody was paying any attention whatsoever. And in fact, it took more or less another 20 years before Floyd Loop from the Cleveland Clinic showed the evidence of using a left internal mammary, which nowadays, I'm sure everybody in this room would use in every possible patient. Of course, there have been other people who have contributed, like my good friend David, with the ARTS trial, the ever big trial ever conducted, and we are looking forward to the long-term results, which I'm sure will be more significant than the first one. And Mario, again, I'm not citing him because he gave good words about me, but because his contribution has been immense and is a demonstration how you can be a good surgeon, but at the same time, you can be a good science. And I'm afraid this is what we need. We need a good science because we need clinically based evidence. To say this is my opinion is not very good. Opinion usually lead to ignorance, whereas science lead to knowledge. Now, having said all of this, and I'll stop talking about me very soon, I was appointed to be a chair in 1992, I think, in Bristol. It wasn't a very good time because there was a big scandal going on called the Bristol Children Scandal, and you may or may not know. But anyway, my interest, among some other things, has been very much in the area of warm cardioplegia with Antonio Calafiore, and also in normothermic cardiopulmonary bypass, which I hope have contributed to the development and the implementation in clinical practice of these two techniques. However, I had this fixation that I wanted to get rid of the heart lung machine to do coronary surgery. And of course, at a very early stage, I have been to Brazil and seen people like Benetti and Buffalo doing some of these operations. Admittedly, these were rather empirically, and they were almost entirely confined to the graft on the LAD and into the main right. And I remember asking Ennio Buffalo, why don't we do the circumflex? And he said, no, you can't do that, because the moment you lift the heart, the blood pressure goes, and, you just can't do that. So obviously, I had an interest. I wasn't the only one. Lots of other people starting to have a serious interest about off-pump in the middle of the 90s. We had problem. I mean, I call this the technique which we use in Bristol, but there are many other techniques. We developed, I believe, one of the first stabilizers, which subsequently became the CTS. I don't think CTS exists any longer. And subsequently, as you know, there were some much better ones, like the octopus and so forth. But being in an academic institution, we wanted to demonstrate, and there was some benefit in doing this, so we did one of the first randomized trial, which was published in 2001. I'm not going to discuss the results of that, but I will just show you, it's the only slides I'm going to show you results, or just one slide, because one of the main criticism of off-pump, which is still persists nowadays, is that if you're doing an anastomosis on a beating heart, it cannot be as accurate and as good as if the heart is being stopped with cardioplegia. Hence, the reason of poor results. In my view, the reason of poor results is when people don't do this on a base routine clinical practice, and they just do every so often, and it's a bit hard to expect good results. But this is the same study, the same randomized study, where the patient were followed up at 8 years. And as you can see, the difference in patency, there was no difference. It was identical, 89%, whether you had done the operation on pump and off pump. And another good friend of ours, and this, I forgot, and this is also, everybody talk of cardiac event-free survival. As you can see, there are no differences whatsoever. And as I said, another good friend of ours, John Puskas, demonstrated this even more beautifully at 1 year, recatheterizing all these patients with an astonishing patency rate of 90+. So the question is, as long as you know what you're doing and you do it regularly, there isn't any issues about how good the quality of the anastomosis is. So this, in a way, is the past. But where do we go from here? Well, the first thing is that you would expect that a lot of people nowadays are doing off-pump surgery. This is a recent paper published by my lecturer, and if you look at the bottom of these slides, the blue is the percentage of off-pump operation, which reached about 20% in the middle 20s, but now it's gone down to 10%. I'll come to this back in a minute regarding other countries. The problem, in my opinion, is even more worry when you look at arterial graft. Here is the yellow. If you look at the yellow, early in late 90s and early 2000, we were hitting 20, 25, 30%. We now, in this country, down to 10%. Now, I suspect this is not just in this country. For off-pump is a different story. This is something I wrote an editorial in 5 years ago, so it's a bit superseded. But in off-pump, you got this crazy situation where there will be countries like Japan, India, places in South America, where effectively they do 100%, maybe not 100%, but 90-something percent off-pump. And you got country, particularly in the so-called Western world, where the practice is in the order of 10% or less. There are all sorts of reasons why this is happening, which I can't enter into it, but this is actually the reality. So where do we go from here? What is the future expecting us, or you guys, because I won't be around working for much longer. Again, I was asked to write an editorial on cardiac surgery, a brief history of the future, and I start by saying that a cardiologist and a surgeon, after 30 years transgalaxial traveling, they now come back to Earth. They just happen to be married as well. The wife is a cardiologist who obviously they need to get back to practice to make a living. And she realized that everything has changed. And really, she hasn't got a clue because there are new technique, new device, new catheter, new balloon. And more or less, she has to retrain completely from scratch. The surgeon, on the other hand, he looks around and he said, well, nothing much has changed. Business as usual, he says. And actually, he says, the time I spent away, it really hasn't changed much my perception of life at all. So what does he do? He says, well, I think he said, I feel then I should focus my energy to continue to argue whether coronary artery surgery should be done on pump or off pump, whether I should use one artery or two, whether I should use a tissue or mechanical valve, whether the sternum should be split entirely or just a little bit, or whether small incision, which, by the way, is a misnomer for so-called minimally invasive, is not minimally invasive, it's minimal access, should be used in different procedure, whether it's valve or other things. So really, this is I think it was, and it still is, a very serious delusion and denial syndromes. Now, if you carry on doing the same things here over and over, I'm paraphrasing here Einstein, you are classified or described as affected by insanity. So you're doing the same things over and over again, and you expect to see a different results. It doesn't get better unless we do better. So how are we going to do better? Well, first of all, we had to start thinking outside the box, perhaps paraphrasing again Leonardo, because at the end, what we need is to translate the research into benefit for patients, which are our main customer. But also we have to train to new things the next generation. And here is where I'm very critical, certainly of my national UK society, where, or the organ which are responsible for training, where we are so backwards, we haven't encouraged the introduction of new technique, and we have failed completely our trainees, particularly with technique like, for example, catheter wires. In this country, you will not be allowed to touch a catheter or a wire to do anything whatsoever except do the usual surgery, which we've been doing for the last 30 years or longer than that. So again, what do we do with coronary surgery? Now, there is no question that post-COVID, but it was coming anyway, COVID or no COVID, the volume of coronary surgery has reduced maybe by 30 or 40%. So in the past, I described coronary surgery as an operation for everybody. One of the guys who trained me, actually, Donna Ross, used to say, for dogs and pigs, everybody can do this operation. So now we got perhaps an opportunity, because the volume of what needs to be done is shrinking, to turn this into a specialized discipline. After all, this is the case for mitral valve, for complex aortic, and so forth. So if we want to make some changes, first of all, we have to do well what we already know we can do. Perhaps it can be off-pump. I'm not advocating using off-pump for everybody, but certainly there are indications for the use of this technique, as there are indications for the use of using the heart-lung machine. The same applies to arterial graft. I'm not saying we should put arterial grafts in everybody. In fact, quite the contrary. We should perhaps look at minimal access, and most important, enhance pre- and post-operative recovery. I won't bore you with this, but we just done a survey of readmission in the United Kingdom for coronary surgery 1 year after the operation, and the figures are staggering. Half the patients are readmitted at least once for some complications, which most of the time, as a matter of fact, is related to arrhythmia. So what more I could, how can I say, advise you on the future? I've almost finished. Now, Torre Grossa, another good friend of ours, a very enthusiastic, and he's got all my admiration. He's doing very complicated things, which I could never do, actually. However, allow me to be a little bit critical. We're still doing the same operation. And let me be a little bit more critical, because coming back to aeroplane, I couldn't fly aeroplane, but most of the development of Concorde, you may or may not know, was in Toulouse in France and in Bristol. So it just happened, and I operated on one of the test pilots and one of the engineers. So of course I said, I want to see what you do and where you did it. And they took me to the place where the engineering was taking place, which they called the big shed. And on the wall in huge letters, there was this captation, which would say, it takes a minute to understand it, keep it simple, what does not go into an aircraft cannot go wrong. And this is why I like simplicity, but I'm not suggesting that the work that Dora Grossa is doing should not be done. The problem I got is that we're doing the same operation which we did 30 years ago. The reason why that operation really didn't work so well is because we had problem in taking the mammary artery, and most of the time we crack a few ribs, and the patient got problem thereafter. In fact, at the top, you can see a mammary which is anastomosed to the LAD, and believe it or not, since you wouldn't reach, this was the first hybrid we actually ever did, I had to lengthen it with an inferior epigastric. Some of you won't even know or remember where the inferior epigastric is in the groin. It's a crazy artery to use. So really, there is a future here, particularly when it comes down to mobilization of the mammary, whether it's done with a computer or a robot, I should say, or whether it's done for the people who don't have a robot with a straightforward thoracic endoscope and an harmonic scalpel. Right. The final thing, which is a bit of a speculation, and I finish, I hope I'm not overtaking my time. Refractory angina. I don't know if you ever heard about this, but refractory angina is a very condition in which there is no treatment. You can't have PCI, you can't have surgery. All the medication they give you, they don't work. And these patients have got constant angina, relief not all the time, but most of the time by straight morphine. Now, there is an awful lot of people with refractory angina. In fact, we reckon 5 to 10% of the stable coronary artery patient. Now, the cardiologists are obviously understood, and this is a potential area for development. And now they are using all sorts of fancy stuff, which are called a reducer. Effectively, this is an old technique which goes back to Bax, who was one of the first to look how to do coronary surgery or how to resolve the problem with coronary artery disease. So what they do, they put a balloon into the coronary sinus. And by doing this, you increase the pressure upstream. And by doing this, the idea, you improve perfusion. So my question here is, why not doing something rather different? So if you got a patient who cannot have an angioplasty, who cannot have PCI because the vessels are all in a mess, what about bypassing the left anterior descending vein? Of course, you have then to tie the vein proximally. And effectively, what we're trying to achieve here is just retrograde perfusion. This is what you do if you use retrograde cardioplegia to do whatever, an aortic valve replacement. Of course, you can then take it a step further if this is not possible, and why not to bypass directly into the coronary sinus? I understand this is a bit of a provocative suggestion, and I'm too old to embark into this, but perhaps somebody here may have some enthusiasm to look into this. So I've really finished now, and the surgeon is now returned from Mars, and he has realized that really very quickly he has to readjust his future if you want to carry on making a living. The changes are not going to be absolutely minor, but they're going to be pretty serious. But he has to embrace, as I said, some of what we already do, and perhaps we should do it better. And this will require very serious recognition from the national specialty to implement major changes in the training curriculum, something which in this country is completely lacking. I don't know the US or other country, but I wouldn't be surprised if it's exactly the same story. So the end result is likely that it will be merging of the interventional cardiologist and the cardiac surgeon into a new specialty, and it will be a chimera. Once again, thank you for inviting me here and for listening to me. Thank you. Thank you.
Thank you. It's my great privilege to present our second Lifetime Achievement Award to my dear friend, Professor David Taggart, who has almost as many letters after his name as Mario does. So it's a real honor, and you can see from this very cursory summary of his career that it has been a very illustrious one. You all know that, and that he has been professor, the tenured professor of cardiovascular surgery at Oxford University for now 20 years. He's also been president of the UK Society of Cardiothoracic Surgery in Ireland, and interestingly and importantly for our organization, he was the creator and founder of the Oxford Masterclass, which was the precursor for our International Coronary Congress. You know him as a vigorous advocate for coronary bypass surgery, a truth teller to cardiologists, a revealer of improprieties in clinical research and in the reporting thereof, and a vigorous advocate for cardiovascular surgical patients. He is the co-founder of the International Coronary Congress, and it's been my great privilege to work with him closely in all of these past 9 meetings, and of course on this year's 10th meeting as well. It was not an accident that we came to the UK for our 10th annual meeting, and I'm delighted that it is here in his home country. This is one of the early, I think the first ICC meeting, and Mario Gaudino and I and David, we're here with alcohol in front of us. One is told never to have a photograph with alcohol in front of you, but this seems too true to avoid. So here it is, the 3 folks that put this together at the beginning and have kept it going. In 2016, we were in New Delhi. Naresh Chauhan, who will be here later in this meeting, gave David an award, and it was a special moment. These are other special moments. You see Gianluca Torregrossa at one of our early meetings in New York, along with Sam Balki. But I know David also as an intrepid snowboarder. You can see him pointing to the sign that says out of bounds. That's, of course, precisely where we went. He's also a fisherman. This is the 2 of us in Iceland. You got to admire the bucket hat to protect him from the northern lights. I don't know who is looking at whom with more interest. You can see the monkey looking at David and David looking at the monkey, and I'm just not going to put any thought bubbles on either one of those. I'll leave that to your imagination. David and I have traveled the world. Here we are in Tokyo. We've written a book together. We've been to New York. That's Kath, his significant other. You don't know the romantic side of Professor Taggart, but there it is. And with my wife, Jane, and his significant other, Kath, in Central Park. The International Society for Coronary Artery Surgery would not be what it is without Professor David Taggart. It might not exist at all without Professor David Taggart. And therefore, it is my great honor and privilege to present to him this Lifetime Achievement Award.
Thank you, John. It's a wonderful position to be in, to be given an award like this, because most of us in this room will have done things where we've achieved far beyond what others have done. I have to say, first, I was meant to be giving a lecture on where is coronary artery surgery just now, where will it be in 10 years, but the truth is I gave most of that yesterday in terms of explaining why CABG is still definitely the best treatment for most patients who require mechanical intervention for coronary artery disease, both for multivessel disease and for left main disease. And what we struggle with is not the evidence basis for what we do, But what we struggle with is the fact we are not the gatekeepers to the patients. Now, there is no question we should be trying to improve the way we do coronary surgery, but it doesn't deny the fact that just now, at this point in time, we do provide the best long-term outcomes for patients, and it's important we continue to offer that to patients and that we don't forget it. So I will not be giving that lecture again, you'll be glad to hear. I had in fact planned to talk about the latest updates to the arterial revascularization trial, with particular reference to the fact that in the next few months we will have the 15-year outcomes of that trial, but I'm sure that can wait for another meeting. So on that point, I'm going to round up these few words, and I want to particularly acknowledge Mario and John, with whom I've worked for the last 10 years. Excuse me. But in particular, John Puskas has become a particularly good friend over that time period. He is a remarkable surgeon. He's a remarkable clinician, but he also has other characteristics that make me very privileged to be his friend. He's a very approachable man. He's a very honest man. He's someone that you can really turn to for advice. And when you're out with him, he's been to my apartment in Chamonix several times with his wife. He is absolutely the most wonderful, entertaining company. So, John, thank you for everything.